مساء الخير طلابنا الأعزاء طلاب كلية الصيدلة مرحلة ثالثة and أهلا وسهلا بكم in the fifth lecture about the drugs acting on autonomic nervous system. We talked about the autonomic nervous system in the first lecture, the physiological, the biological, and even the anatomical part or divisions of the system. In the last 3 or 4 lectures, also we talked about the cholinergic agonist and antagonist, and we talked about the pharmacological uses, the therapeutic application, the adverse effect of this medication. Now we are talking about the last part of the drug acting on autonomic nervous system, which is adrenergic drugs. And as you know, adrenergic drugs can be divided into 2 main divisions: adrenergic agonist and adrenergic antagonist. So in the cholinergic drugs, we have 2 divisions, agonist and antagonist, and here also we have 2 divisions, adrenergic agonist and adrenergic antagonist. So just to remind you, the adrenergic receptors also, these receptors called adrenergic receptors because it works on the adrenaline or noradrenaline or epinephrine or norepinephrine. These drugs also called adrenoceptor or adrenergic receptor. There are 2 main components of the chemicals that work on the adrenergic receptors, either as adrenergic agonist or what is called sympathomimetic, which is activate this receptor. And the second part is by using a chemical substance that bind to the receptor without inducing any kind of pharmacological activity. And this kind of medications or chemical substance called sympatholytic or adrenergic antagonist. And sympathomimetic, as I mentioned previously, these like activate the sympathetic receptor or the adrenergic receptor or the adrenoreceptor. The mechanism of these substances, the sympathomimetic, can be divided into 2 main divisions, 2 main compartments, 2 main mechanisms. The first one, direct acting agonist, and I think we mentioned this term in the cholinergic drugs. And here we have the same definition. So a direct acting agonist is by occupying or binding to the receptor and mediating and inducing specific pharmacological activity. Indirect acting agonist is by either enhancing the release or blocking the reuptake of norepinephrine. And in this situation, there will be high concentration of norepinephrine in the synaptic cleft, and we can get massive or a huge effect of adrenergic activity. So you remember we mentioned this anatomical division or distribution of the adrenergic receptor, and we mentioned that. So this is the sympathetic system, and we mentioned that in the autonomic ganglia. In the autonomic ganglia, there's a nicotinic receptor activated by acetylcholine. However, in the post-ganglionic neuron, this neuron release norepinephrine, and we have here adrenergic neurons, so adrenergic receptor. So this is in the sympathetic part of the autonomic nervous system. In the adrenal medulla, which is slightly like sympathetic part, this part of the autonomic nervous system also activated by cholinergic activity by releasing of acetylcholine. However, adrenal medulla releases epinephrine directly to the blood circulation, and again epinephrine binds or occupies adrenergic receptor in different body tissues and organs. You remember my student in the last lecture we mentioned or we talked about the process of synthesis, storage, release, and then binding of the acetylcholine to host receptor. And finally, we talked about the mechanisms of removal of acetylcholine from the synaptic cleft. Here we are going to talk about the same steps, but here we are talking about the norepinephrine instead of acetylcholine. So we have we have synthesis, storage, release, binding of norepinephrine, and finally removal. And again, why we need to know all these steps in details? Because there's a wide range of chemical substances, of medications that have been developed to interact with each steps. And these medications either activate or inactivate adrenergic activity. So this figure is very important and can summarize the next 3 or 4 slides of my lecture today. So the first step, as I mentioned previously, synthesis of norepinephrine. And you know, the mainstone of norepinephrine is tyrosine, and hydroxylation of tyrosine is the rate limiting step. Hydroxylation of tyrosine can produce dopa and then dopamine. And dopamine is uptaken inside the vesicles. And you remember we mentioned that these neurotransmitters, norepinephrine, acetylcholine, should be stored inside the vesicles or inside specific vesicles in the terminal endings. Why? Because these neurotransmitters are quite sensitive to the action of hydrolytic enzymes. And in this situation, we have MAO or MAO or monoamino oxidase enzyme. So the second step, as I mentioned, dopamine entered a vesicle and converted to norepinephrine. And norepinephrine are protected inside this kind of vesicle. This step, uptake of dopamine to the vesicle can be inhibited by specific chemical medications such as aspirin. And norepinephrine stays stored in the vesicles without any kind of release until there is a kind of action potential. There's action potential comes through the axon that causes release of the calcium, and high level of calcium in the intracellular part can induce the release of norepinephrine in the synaptic cleft or in the synapse. So the third step is the release of norepinephrine. Again, this step also can be blocked by specific drugs such as guanethidine. And we are going to talk about all these medications in details in the next few lectures. And some of these medications we are going to talk about in fourth stage. So now norepinephrine is being released to the synaptic cleft. Some of the norepinephrine binds to the postsynaptic receptor to induce specific pharmacological activity, such as muscle contraction, muscle relaxation, inhibition of a specific enzyme, activation of protein synthesis, etc. And again, some of norepinephrine bind to another adrenergic receptor, but this receptor located in the presynaptic part. So we have postsynaptic receptor, and again we have a presynaptic receptor. And I think I asked you about like kind of a homework, why there's, or what is the function of the presynaptic receptor? A presynaptic receptor is kind of autoreceptor. What do we mean by autoreceptor? Autoreceptor, when there's binding of a specific agonist to the presynaptic receptor, this binding, that kind of agonist will cause inhibition of further release of norepinephrine. Inhibition of further release of norepinephrine. So it is kind of autoregulatory mechanism. This autoreceptor responsible for autoregulatory mechanism. This receptor responsible for prevention of high concentration of norepinephrine in the synaptic cleft. So some of norepinephrine bind to the presynaptic part. Some of norepinephrine is inactivated by specific enzymes such as COMET, catechol, or methyltransferase, and MAO, which is another enzyme. Removal of norepinephrine, as I mentioned previously, some of norepinephrine moves out of the synaptic cleft, and others can be again reuptaken to the presynaptic neuron. And reuptake of norepinephrine is inhibited by, again, wide range of drugs, such as serotonin, SNRI, serotonin, norepinephrine reuptake inhibitors, which is very famous medication, can be used for treatment of wide range of psychological disorders such as depression and anxiety, post-traumatic anxiety, etc. Also can inhibited by cocaine, can inhibited by imipramine, which is a tricyclic antidepressant. We are going to talk about most of this medication in the fourth stage, inshallah, in the drugs acting on the central nervous system. There's something I think we need to talk about in this part of our lecture today. As adrenoreceptor or adrenergic receptor use two kind of second messengers. Either cyclic AMP or phosphatidyl inositol and cyclic AMP. Also, we mentioned here tricyclic antidepressant medications such as imipramine and other medications such as serotonin, norepinephrine reuptake inhibitors such as duloxetine also can inhibit the reuptake of norepinephrine into presynaptic neurons. By what? Because this kind of reuptake uses specific mechanism, which is sodium chloride dependent norepinephrine transporter. So this medication can inhibit that kind of transporter and increase the level of norepinephrine in the synaptic cleft. So what about the adrenoceptors or adrenergic receptor? There are two main kinds of adrenergic receptor. And you remember, we mentioned that there's so many kinds of cholinergic receptors. There's nicotinic and there's muscarinic. And again, for muscarinic receptor, there's M1, M2, M3, M4, M5. Here, for adrenergic receptor, there are two main divisions: alpha adrenoceptors and beta adrenoceptors. And you can see there's these receptors vary in terms of affinity and potency. So epinephrine and to less extent norepinephrine is there's high affinity of this medication to alpha adrenergic receptor. However, for beta adrenergic receptor, isoprotrinol has or demonstrate high affinity toward these medications. As I mentioned previously, we have like two main kind of alpha adrenergic receptor, and there's alpha 1 and alpha 2, and alpha 1 receptor available in post-synaptic part. We have two main kinds of adrenergic receptor. We have alpha and we have beta receptors. And again, for regarding of alpha receptor, we have two main divisions, alpha 1 and alpha 2. So what about the distributions of these receptors? Alpha 1 receptor available in post-synaptic part on the effector organ. However, alpha 2 receptor available in the presynaptic neurons, And as I mentioned previously, the main function of alpha 1 receptor is activation or binding of norepinephrine to alpha 1 receptor, cause kind of activation of a specific pharmacological activity. However, binding of norepinephrine to alpha 2 receptor causes kind of autoregulatory mechanism. This autoreceptor or binding of norepinephrine with this autoreceptor causes inhibition of further release of norepinephrine. So these are two main differences in terms of pharmacological activity and in terms of distribution. Is there any kind of differences or dissimilarities between these receptors? The answer is yes. Alpha 1 receptor involves a specific second messenger, such as DAG and IP3. And I think we mentioned these second messengers in the last lecture. For alpha 2 receptor, this receptor decreases production of a specific second messenger, which is cyclic AMP. So there are three main differences between alpha 1 and alpha 2 receptors. And again, why we need to know all these details between the receptors? Because there's a wide range of drugs work on this receptor, inducing, stimulating, activating a specific pharmacological activity. And again, this pharmacological activity could be therapeutic effect or could be adversable or side effect. So here we have two examples. Say, for example, we have alpha 1 receptor that high affinity for phenylephrine or phenylephrine. So now I can imagine what will be going on when phenylephrine bind to alpha 1 receptor. However, binding of clonidine with alpha 2 receptor, or the affinity of clonidine to alpha 2 receptor is much high to alpha 1 receptor. And again, I can imagine what will be going on when clonidine bind to alpha 2 receptor. Again, as I mentioned previously, there are two main divisions of adrenergic receptor. There's alpha and there's beta receptors. And for alpha, there's alpha 1 and alpha 2. And again, for beta, there's beta 1 and beta 2. And some researchers now mention that there's again subdivisions of beta 1 and subdivision of beta 2. For alpha 1 receptor, again, there's subdivision. So we have alpha 1A, alpha 1B, alpha 1C, and alpha 1D. And here we have like very important example. So we have tamsulosin. This drug is a selective alpha 1 antagonist that widely used for treatment of benign prostatic hypertrophy. And honestly, this kind of subdivisions of each receptor can explain for us why some medications is much more specific on particular organ rather than another organ. So we can see there's like for each chemical substance there's kind of specificity, and this specificity can be attributed for many factors, for many reasons. One of them, there's like subdivision for each receptors. So what about beta adrenoceptors or beta adrenergic receptors? Again, for beta receptors, there's kind of like order of potency. So isoproterenol is much more potent toward this receptor than epinephrine and again than norepinephrine. Beta 2 adrenoceptor again can be subdivided into another or groups or subgroups. These are beta 1, beta 2, and beta 3 receptors. Beta 1 receptor have approximately equal affinities for epinephrine and norepinephrine. However, beta 2 receptors have higher affinity for epinephrine rather than norepinephrine or noradrenaline. This table is very important, and I would recommend, you have to keep this table in your mind, because we are going to need this table in the next few lectures and even in next year, inshallah. So this table summarizes the distribution of adrenergic receptors, whether they are alpha 1, alpha 2, beta 1, and beta 2. So it summarizes the locations or distribution of each receptor, summarizes the physiological action or function of each receptor. So binding of a specific agonist, or now I can expect the effect of agonist or antagonist when binds to these receptors. So say for example, alpha 1 receptor available mainly on smooth muscle vasculature, and binding of a specific or particular agonist with this receptor can cause vasoconstriction. So vasoconstricting of blood pressures, blood vessels can increase peripheral resistance, can increase the blood pressure. Also, binding alpha 1 receptor in your eye can cause mydriasis, and also can increase the closure of internal sphincter of the bladder. So again, I can expect the pharmacological activity, I can expect the therapeutic activity, and I can expect the side effect, and also I can expect the drug-drug interaction by knowing the mechanism or the function of each receptor. Alpha 2 receptor, as I mentioned previously, it is autoregulatory receptor responsible for the autoregulatory mechanism, and binding of agonists with this receptor can cause inhibition of norepinephrine release, and again inhibition of acetylcholine release. And again, binding of specific agonists with alpha 2 receptor can cause inhibition of insulin release. What about beta 1 receptor? Beta 1 receptor available mainly on cardiovascular tissues, and binding of a specific beta 1 agonist to its receptor can cause increase in the heart rate, or what is called tachycardia. Tachycardia means high or increasing in the heart rate. So this agent demonstrates positive chronotropic effect. Again, binding of agonist with beta 1 receptor can increase the myocardial contractility, can increase the force of contraction, and in this situation we call this agent as positive inotropic agent. So binding a specific medication or a specific medication with agonistic activity with beta-1 receptor can cause a high blood pressure, a high or increase heart rate and cardiac output, and increasing cardiac output and blood pressure. Also, this medication or binding beta-1 receptor with its receptor can increase the release of renin. And in this situation, we have like renin, angiotensin, aldosterone, and again, further sodium and water retention. Beta-2 receptors available mainly on the vasculature, on the smooth muscle of blood vessels and the uterus. So, beta-2 agonist can cause vasodilatation and decrease in the peripheral resistance or decrease in the blood pressure. Also, beta-2 agonist can increase muscle and liver gluconeogenesis. Also can increase release of glucagon, and finally, beta-2 agonist can relax uterine smooth muscle. So we have medications such as salbutamol, which is beta-2 agonist. These medications have two main pharmacological indications. It is bronchodilator, widely used for treatment of asthma. Also can relax uterine smooth muscle and prevent premature contraction أو التقلصات المبكرة لما قبل الولادة. So we have very important term here, which is desensitization of the receptor. What do we mean by desensitization? There's like a general rule in pharmacology. When a specific receptor exposed to permanent or to high concentration of agonist for long duration of time, that will reduce the responsiveness of this receptor. And this phenomena called desensitization. Desensitization. What do we mean by sensitization? It is lose the physiological action of a specific receptor after exposure of this receptor to specific agonist for long duration of time. And there are three main mechanisms have been introduced to explain the desensitization. First of all, sequestration of the receptor. There's kind of inactivation of the receptor. And again, the second mechanism, downregulation. And what do we mean by downregulation? There's decrease in the receptor density. There's a decrease in the receptor concentration. There's a decrease in the receptor number on that neuron. And this another mechanism can explain the desensitization. And the last mechanism is the inability of to couple to G protein. And this again can explain the desensitization or the mechanism of the sensitization. So, what are the characteristics of the adrenergic agonist, such as norepinephrine, such as epinephrine, isoproterenol, etc.? Most of these medications are derivative of beta-phenylethylamine. And there are two main chemical characteristics of these medications. Or there are two important factors that can define the pharmacological activity of these medications. First of all, number and the location of hydroxyl substitution on the benzene ring. And again, the nature of substitution of amino nitrogen. And let me explain here. So, number and distribution of hydroxyl group on the benzene ring can determine the pharmacological activity. And again, we have the distribution here on amine molecule, again, can affect or can influence the pharmacological activity. So when we talk about adrenergic agonist, it is very important to talk about the catecholamines. So what do we mean by catecholamines? Catecholamines is wide range of chemical, it's not wide range, sorry, it is like specific kind of medications. These medications characterized by 2-hydroxyl group bind to benzene ring. 2-hydroxyl group bind to benzyl ring. So we have like 3 or 4 main catecholamines. We have norepinephrine, we have epinephrine or noradrenaline and adrenaline again, and we have isoprotrinol. And you can this kind of similarity in terms of dihydroxybenzyl group, which is like the cornerstone of this molecule. So these are the catecholamines. We have like epinephrine, norepinephrine, isoprotrinol, and dopamine. So what are the characteristics of these medications? What are the main pharmacological characteristics or criteria of these medications? First of all, these medications have high affinity. So they have high potency. What do we mean by potency against طلابنا? Potency means very low concentration of chemical substances can mediate, can stimulate like massive pharmacological activity. So the potency refers to weight or concentration of the substance. When we say this is very potent substance, it means very low concentration or small quantity of this medication or substance can induce a huge effect. So these medications are very potent. Again, these medications or catecholamines is rapidly inactivated by specific enzymes such as COMET, which is catechol or methyl transferase, and MAO, which is monoamino oxidase. And the last criteria of these medications are poorly penetrate to the central nervous system. Why? I think we can expect these medications is very polar. So these medications are charged molecule that cannot penetrate the blood-brain barrier. So the effect, the pharmacological effect, the side effect of these medications is very low on the central nervous system. So these are catecholamines. We have another kind of medications which are non-catecholamines. And the main difference between catecholamine and non-catecholamine is in terms of chemical composition, in addition to the pharmacological activity. So these medications lack the catechol hydroxyl group. And you can see these non-catecholamines lack hydroxyl group on the benzyl ring. So these medications are not inactivated by catechol or methyl transferase. These medications include phenylephrine, epinephrine, and amphetamine. And again, these medications is a poor substrate for monoamino oxidase. And now we can expect these medications have longer duration of action compared to catecholamine. So if I ask you why non-catecholamines or why phenylephrine have longer duration of action more than catecholamines or norepinephrine or epinephrine, because these medications are a poor substrate for internal or extrinsic enzymes such as monoamino oxidase and catechol or methyl transferase. So these medications have very long duration of action, and some of these medications can be given orally, such as ephedrine and pseudoephedrine. However, catecholamines cannot be given orally. Another dissimilarities between catecholamines and non-catecholamines is the ability to penetrate the blood-brain barrier. These medications, I'm talking about non-catecholamines, have high lipid solubility, So this medication can penetrate the blood-brain barrier easily, and the extent of pharmacological effect and side effect on the central nervous system is much more than catecholamine. So what is the mechanism of adrenergic agonist? And I think the mechanism of adrenergic agonist is a bit similar to the mechanism of cholinergic agonist that we talked about in the last 2 or 3 lectures. So here again, we have direct acting agonist, and again, we have indirect acting agonist. But the only thing which is different between adrenergic and cholinergic agonist, we have a third group for adrenergic agonist, which is called mixed action adrenergic agonist. So what do we mean by direct, indirect, and mixed acting adrenergic agonist? Direct acting agonist, so this medication bind to the post-synaptic adrenergic receptor, and mediate specific pharmacological activity. What do we mean by indirect acting adrenergic agonist? This medication enhances the release of norepinephrine. From the vesicles, and again, in this situation, there's high concentration of norepinephrine in the synaptic cleft, and increasing the adrenergic activity. So what do we mean by mixed action adrenergic agonist? These medication act by both mechanism, by direct and indirect mechanism. So mixed acting adrenergic agonist can, first of all, can bind to the post-synaptic adrenergic receptor, and again, by increasing the release of norepinephrine from vesicles. Thank you for listening طلابنا الأعزاء، وأتمنى تكون main idea and the most of the details of this lecture, or you have got the main idea and the details of this lecture. If you have any question, if you think there's something you need to find out, if you think there's something which is not quite clear, all you need to do is just to leave a comment in our Google Classroom, and we are going to reply your inquiry or your question as soon as possible إن شاء الله. See you in the next lecture إن شاء الله، ونتمنى لكم أوقات سعيدة وشكرا جزيلا لكم.